So we invite our next speaker, Dr. Rajiv Karnik, sir, and he's going to speak about heart failure with preserved ejection fraction.
Good afternoon, dear friends. It's really a great, proud privilege to be on this prestigious podium of Academy of Cardiology. And my heartfelt thanks to Pelejani sir, Dr. Satyan Sharma, Dr. Gupta ji, Ajit Desai, and all the organizing committee to choose me for this. So dear friends, we are going to talk about heart failure with preserved ejection fraction. And just now you heard from Dheeraj Kumar that it's a little difficult subset of heart failure to treat. And it used to be called as the conundrum of heart failure with preserved ejection fraction, hardly any treatment which can be useful, and so on and so forth. Actually, I started my practice, cardiology experience in early 80s, about 45, nearly 43 years back. We didn't have anything at that time. We just had digoxin and diuretics at that time. It was 1986 when hydralazine, nitroglycerin came, nitrates came, and subsequently in 87 ACE inhibitor and then ARBs and mineralocorticoid blockers and beta blockers came. And you saw just now this slide that this is how the evolution occurred. But all these drugs, you will find that they were mostly for heart failure with reduced ejection fraction. There was hardly anything for preserved ejection fraction. That time we knew that when the heart failure has preserved ejection fraction, the muscle is not weak. So what we had at that time, digoxin, will not work because digoxin is going to increase the contractility. In fact, the calcium entry into the myocardial cell will make it more stiff and diastolic dysfunction will worsen. So at that time, we were very cautious about using not using digoxin, but we started trying nitrates, then we started trying calcium blockers, thinking that maybe there is a concomitant coronary artery disease, microvascular dysfunction, endothelial dysfunction, so on and so forth, including even phosphodiesterase inhibitor in the RELAX trial, and various drugs were tried, but nothing really worked. And as you can see here, these are the large trials. And you can see the 2003, this CHARMS preserved, 2008 I preserved, ribesartan preserved, then perindopril and seniors and digoxin and TopCat with aldosterone antagonist. And last but not the least, which Dheeraj Kumar pointed out about Paragon. So when all these trials were failing, what was thought that what can really work is comorbidity. Because all those comorbidities which are producing heart failure with preserved ejection fraction, they should be treated adequately. Just treat the congestion to begin with when the patient comes with impaired, acute decompensation, and subsequently go for treatment of comorbidities. And these were all the comorbidities including ischemic heart disease, diabetes, CKD, hypertension, so on and so forth. And in fact, these algorithms for treatment, management of heart failure with preserved ejection fraction, as you can see that this PEF2, it is diagnosis with clinical symptoms, echocardiography, and biomarkers, and subsequently immediately comes to the comorbidity and etiologic assessment, because that was the only thing which was thought earlier which will really work. But last 5 years have been really exciting for the management of treatment of heart failure with preserved ejection fraction. Basically, because of this great advantage that we have seen with SGLT2 inhibitors, starting with empagliflozin followed by dapagliflozin. So on the left side, you will see that heart failure with reduced ejection fraction, so many drugs are there with 4 pillars and class 2A, 2B, additional 3, 4, so coming to about 7 pillars. And on the right side, you will see just one SGLT2. And that came basically after this Emperor Preserved trial, which was just 2020, when during this COVID time, this trial was published when it was supposed to be published in London in during ESC, but then it was published just online during the COVID time. And then it was with nearly 6,000 people, very nicely conducted, and there was relative risk reduction of 21 with absolute risk reduction 3.3. So 100 divided by 3.3 is about 31. So number needed to treat just 31 patients, and you can have one benefit with CV death and heart failure hospitalization. And especially this benefit was carried by heart failure hospitalization for heart failure, as you can see here in this table. And so if you just shift this one component benefit with heart failure with preserved ejection fraction, the benefit of empagliflozin, then that hazard ratio is improving from 0.79 to 0.73, additional 6% gain in this thing, benefit of HF reduction, hospitalization for heart failure reduction. And it was not only this Emperor preserved, but lot many Emperor group trials came, including Imperial, Emperor this thing, then Empa Vision, so on and so forth. So that was all about this long-standing heart failure. What about acute heart failure? EMPULSE study. In EMPULSE study, those people who get admitted with acute heart failure, just with a median time of 3 days, within 3 days after admission, when the patient was already on diuretic, at that time empagliflozin was started. And then both similar was seen even with dapagliflozin, because normally most of the trials initially give good dose of diuretic, stabilize the patient, and after patient is stabilized, then they start with this foundational treatment. But this SGLT2 has proven to be an exception to that. Even along with diuretic, if you give, in fact, the urine volume increases, the weight reduction, the body weight improvement takes place. And so this was EMPULSE with this thing within 3 days of median time. The drug was, this empagliflozin was given, and as you can see here, there is a good benefit and equal benefit. Ejection fraction less than 40%, more than 40%, almost equal. There was another EMBRACE trial, which was like CHAMPION study. Cardiomems were implanted in the pulmonary artery to see the pulmonary artery diastolic pressure, which was done earlier in CHAMPION to guide the diuretic therapy and preempt the upcoming heart failure. And in this particular EMBRACE study also, it was seen that this empagliflozin reduces diastolic pressure, and especially this Emperor pool and Emperor reduced and preserved, if you pool together, there are some findings that you can really see. That why does heart failure in the preserved ejection fraction occurs? It is not because of myocardial contractility loss, but it is because of interstitium of the myocardium, which is stiff with the collagen. Even the myocardial sarcolemma is also stiff. And to this, for this particular, to see whether empagliflozin works or not, this was a biomarker study. And procollagen 1 and procollagen 3, when it was assessed in some cases, not all the cases, and it was seen that it was effectively benefited, and equally again with ejection fraction less than 40 with reduced ejection fraction and with preserved ejection fraction. And so also the renal benefit was also seen in both the reduced ejection fraction, 2 to 4-fold benefit with empagliflozin. And immediately after empagliflozin, the next year the DELIVER trial came. Again, I had witnessed this in during ESC. 18% relative risk reduction, and especially at this time they thought that not only heart failure hospitalization and death should be considered, even going to the emergency room and taking extra diuretic dose, that should also be considered, because as you can see in this particular graph, the middle graph is with this thing, going to for the emergency visit and getting escalation of diuretic therapy, and that also has different Kaplan-Meier curve. So if you include these two, outpatient diuretic escalation or this thing hospitalization, that becomes more than 50%. And if you include this as an additional benefit in the Kaplan-Meier curve, then this hazard ratio is becoming even more in the DELIVER trial, again additional 6% benefit, and across this entire spectrum, whatever ejection fraction that you can see. So that led to this final concluding position of SGLT2 as class 1. It was class 2A in 2022 guidelines, and in 2023 focused update, now it has become class 1. The only one class 1 after diuretic stabilization is SGLT2. But then again, we should say that should we discard the other drugs? No, because one shoe doesn't fit all. I mean, there has to be some heterogeneity. There should be some different groups in, even with the other previous molecules which we showed that which did not have significant benefit, which you can see here. The candacertan. Again, heart failure with mildly reduced ejection fraction, you can see the benefit. Beta blocker. You can see on the right hand side where the circle is 40 to 49 mildly reduced ejection fraction, more than 50% preserved ejection fraction. You can find that there are this CV hospitalization, CV death, hospitalization. There is a benefit with beta blocker also. Now the TopCat trial which came in 2014, just before this paradigm HF, and then that also at that time there were great hopes with TopCat trial, and then more than nearly 3,500 people with more ejection fraction more than 45, so mildly reduced or preserved ejection fraction. So it was said to be negative, but then if you see on the right hand side where there is a continuous score of ejection fraction, and if you see this 55%, so below 55, so 45 to 55%, so mildly reduced and relatively preserved ejection fraction, there is a benefit in terms of this entire confidence limit is also below the zero line, and there is a benefit. So the conclusion, as opposed to 2013 AHA, November AHA this thing presentation versus recent publication, they said yes, it is not that it is not useful. There was a reduction in the heart failure hospitalization, and as we saw in the continuous curve, there is a benefit, and moreover we said that there is heterogeneity. So if you see the TopCat trial, in some people it was useful, some people it was not useful. So Cohen et al. In this JACC 2020 made these three phenotypic groups. And as you can see here, that the P3 group, which has concentric hypertrophy and arterial stiffness, and then biomarkers, E upon E time more than 15, so on and so forth. And this is the one which has got inflammatory markers, obesity, central obesity, especially in our Indian, and they preferentially respond to spironolactone. This is a paper poster presentation from in HFA Discoveries 2020 from Ukraine. And that also showed that in preserved ejection fraction, the spironolactone reduced delayed the atrial fibrillation distance. So that this is the zoom of that AFib interval. So that is about mineralocorticoid blocker. Now let us come to the second molecule which we said was not shown to be useful in Paragon trial in heart failure with preserved ejection fraction, that is ARNI.
So just a reminder if you can wind up so that.
Yeah, I'll go so Paramount, Paralox, Paraglide were just the initial hypothesis generating trials, but Paragon was a real trial, and which just now Dheeraj Kumar said that it was not useful, but then if you see the p-value is just 0.06, so instead of 0.05 it was 0.06, and confidence interval was also 1.01, so just it was missing. And then if you do some post hoc analysis, there were a lot of groups which were getting benefited with this ARNI. And then especially if you combine Paragon and then this Paragon and our TopCat, then you can again find there are some groups. So just last two slides I will cover. So with this in the guidelines, all the drugs are again included in SGLT2 as class 1 and rest of the drugs as class 2B. And last two slides. So what should be for the clinician, what should be the algorithm? If there is heart failure with preserved ejection fraction, especially decompensated if it has come to you, first of all, optimize the diuretic dose. Still after optimizing, if NT-proBNP is more than 360, if his potassium is less than 4.7, if his eGFR is more than 30, then start this thing. Before that, of course, add SGLT2, as I said, with impulse trial. And if all these points are there, then you add aldosterone antagonist, that is spironolactone. And next step is, after achieving this, still if the patient is in NYHA class 2, BNP is more than 300, BP in diastole in preserved ejection fraction, we take it as 135/80, then you can give ARNI. Ejection fraction less than 57, because Paragon HF had shown specifically the benefit only when ejection fraction was less than 57, not above 57. So, and potassium less than, then only you start ARNI. So after SGLT2, I think another drug which is going to compute, that is GLP-1, which reduces body weight, CRP, so on and so forth. And this is of course futuristic treatment. Probably this ESC 2024 in London, we might hear the fine arts and there's different other futuristic treatment, which is not the subject of today's discussion. Thank you very much indeed.